Welcome to day two of Housing California's 24th annual conference. I am Congresswoman Barbara Lee, and I proudly represent California's beautiful 13th Congressional District, which includes Oakland and Berkeley, California. First of all, I just want to say thank you to Housing California for the invitation to address you today. Housing California truly has been a leader in advocating to end homelessness and housing poverty long before this pandemic, and I am so proud to work alongside you. If this pandemic has taught us anything, it is the importance of security and stability. We are reminded that housing can be a matter of life or death. Our country was facing an unprecedented affordable housing and homelessness crisis long before this pandemic. And now we see those pre-existing inequalities further exacerbated by COVID-19. We must work towards creating more affordable housing and ending homelessness in California. And to achieve that, it must be addressed with a racial justice lens. Redlining and racist housing policy have shut Black, brown, and Native people out of housing for over 100 years. Nearly 90% of census tracts are still racially segregated, and Black and brown neighborhoods are 2 to 3 times more likely to be deeply impoverished. Housing is a basic human need and a basic human right. We must come together to make sure everyone is guaranteed a safe, stable, sustainable place to call home. We must also create efficient and accountable housing and homelessness systems that will protect people and reimagining growth. Again, thank you to Housing California for advocating for a better future, and yes, for advancing racial equity and economic inclusion. Please stay tuned for day two of this conference to learn and take away from conversations that cover tenant-led housing justice movements, reimagining housing as public safety, and later today, please look forward to a kitchen table talk with my good friend, the former mayor of Stockton, California, Michael Tubbs, and Chris Haney, the executive director of California Budget and Policy Center. Thank you all again.
Thank you so much, Congresswoman Barbara Lee, for your inspiring words and for your leadership in Washington. Welcome back, everyone, and thanks to all of you for joining us at Housing California's 2021 Virtual Unconference. I'm Rochelle Reyes-Wenger, System Vice President of Public Policy and Advocacy Engagement at Common Spirit Health, where we have a presence in California as Dignity Health. And I'm a very proud member of Housing California's Board of Directors. First, a huge thank you to our sponsors and the staff and fellow board members of Housing California for putting on this unconference. Additional gratitude to the speakers who took the time from their busy days to lend their insight and expertise. Second, a reminder about a few tips and tricks to ensure that you have the best possible unconference experience. During sessions, feel free to chat with other attendees in the chat box and use the Q&A box to ask questions of our speakers within WOVA. For more tips, the user guide is your friend. If you still have questions, you can email us at conference@housingca.org. Third, be sure to visit the exhibit hall following sessions where you can win prizes. Woohoo! Use the hashtag Housing California 2021 on Twitter and Facebook to help those unable to be here to follow the conversation. You'll see the Housing California team live tweeting sessions as well, and you can go and engage in the conversation there. We look forward to continuing this unconference experience with all of you. I'm honored to introduce our next session, Housing and Health Partnerships, Connecting the Dots, a topic near and dear to my heart. I'm glad to turn it over now to Michelle Schneider from the California Healthcare Foundation to kick off the conversation. Michelle?
Thanks, Rochelle. Good morning, everyone, and welcome to this session. We're really glad you've joined us. As Rochelle said, I'm Michelle Schneiderman, Director of Advancing People-Centered Care at the California Healthcare Foundation. The other panelists and I are super excited to be here with you to try and make the case for more and better partnerships between the healthcare and homeless services sectors, particularly for our unhoused neighbors with the most complex needs. For those of you not familiar with CHCF, we are an independent, not-for-profit philanthropy working to improve the healthcare system for Californians with low incomes and people not well served by the status quo. Our priorities are to get everyone covered regardless of income or immigration status, deliver care better by increasing access and improving the way care is provided to people with complex health needs, and to make care just by removing the structural barriers that prevent people from getting the care they need. Last year, the foundation launched work to improve healthcare for people experiencing homelessness, promoting care that is responsive, person-centered, and focused on the integration of physical health, behavioral health, and social needs. The cornerstone of this integration work will have to be robust and sustained partnerships among the healthcare, social service, and housing sectors. As part of this work, we commissioned Homebase to scan the state in order to learn more about whether and how information or data sharing between the healthcare and homelessness sectors is happening in California. We'll be publishing the results of that scan in the next few weeks, and what you'll hear today is a sneak preview of the findings, particularly some of the bright spots. We hope you walk away from this presentation with a better sense of how the sectors are currently working together and what future partnership opportunities to improve care and end homelessness in California could look like. Now I'd like to pass things over to Julie Silas, Directing Attorney from Homebase, to talk about their findings on cross-sector collaboration in California. Thank you.
Thank you, Michelle. Good morning, everyone. I'm happy to be here. My name is Julie Silas, and Homebase is a nonprofit organization. We've been working around the sector of homelessness for over 30 years, and we work with communities to prevent and end homelessness. We do a variety of work. We're subject matter experts on homelessness, as well as cross-system coordination. We work as a HUD TA at the federal level. We work with counties and cities and local organizations with a particular emphasis in California. And we do a whole host of work working really to establish systems and programs to be able to help people experiencing homelessness achieve housing stability and health and wellness. Most everyone on this call today knows that we are in a crisis, both a homelessness crisis and a housing crisis, and they're really one of the most challenging issues that we're facing. And traditionally, homelessness has been dealt with a small group of organizations at the local level who are working at an intersection, but mostly at the intersection of homelessness. And over time, I think probably in the last 5 to 10 years, there's been some real focus on the social determinants of health and recognizing that people's healthcare and people's lack of housing are all interrelated to a whole host of other things that we face in this country: systemic racism, lack of education, issues around child welfare in the criminal justice system. And as that recognition has happened, more and more efforts have arisen to kind of do that cross coordination and collaboration. And that recognizing that if we don't, things like this statistic will continue to unfold. And we know that people who experience homelessness are at risk of, lots of additional diseases or more exacerbated diseases and death. And what we are going to talk about today is efforts to do cross-sector collaboration, really think about how we can bring different systems together to improve how people are cared for in the system. So just to kind of step back and talk about what do we mean by cross collaboration. So in a lot of communities, we have different systems to help people. So we might have a county that has a Department of Health, and they might have a Department of Housing. And in some communities, they even have a separate department that deals with homelessness. And at the same time, there is a huge sector of folks who are touching all those systems at the same time. And what happens when folks touch those systems is the systems are inefficient and ineffective in the sense that the healthcare system isn't necessarily sharing information with the homeless system of care or with housing. And not only is it inefficient for the systems themselves, but the people who are trying to get help are highly burdened. So they are having to go to multiple systems to tell their story, to explain who they are, to show documentation that they are who they say they are, to meet different levels of eligibility criteria. And as a result, they're overburdened, and we're making their job to try and get housing or to improve their healthcare literally impossible. And I think in California, we've been privileged to recognize the value of cross-coordination. And in 2015, 2016, we started a pilot project called Whole Person Care, which actually inspired communities to come together cross-sector to start work on behalf of some of the most vulnerable folks in their community to collaborate more. And that was a successful program, but it was a limited program. It wasn't across the state. And recently, we are in the process of putting together a new program called CalAIM. And what's unique about that program is, one, it recognizes the value of cross-sector collaboration, but it also recognizes that housing is healthcare. And so, and one component of that program is in lieu of services, which basically allows housing support through the healthcare program through Medicaid. When we undertook the work that Michelle raised earlier about looking at what's going on in California, what we did was we did interviews and did research to find out, well, what are communities in California doing to cross-collaborate? How are they building on their whole person care? How are they anticipating work that's coming up through CalAIM? And what have been some of those hurdles? And what we found is there were 4 major hurdles all around data sharing. And in order to really hold people and work with people in a cohesive way and in a coordinated way, we need to do data sharing, because you don't know if Julie Silas is the same Julie Silas in the healthcare system as she is in housing if you don't do some kind of data sharing. And so data sharing often is the hurdle that prevents really robust cross-sector collaboration. And so we focused a lot on that. And what we found is there are a number of issues. So with privacy, we have systems that are dealing with different rules on privacy, different client consents they have, and oftentimes legal system that is a little bit averse into challenging those systems in order to share information. Then we have systems that are really separate from each other and they aren't interoperable. So as we talked about, sometimes you have 3 different agencies, there's no interdepartmental structures, there's local politics about what each agency can do and how to share or not share. And then even when there's an interest in sharing across those systems, sometimes the technology, the interoperability, the ability to share data from one system to another, the ability to fund what it would take to share data from one system into another doesn't exist. And that also becomes a huge challenge. And then there's data quality issues, which again, each agency may have developed different data standards about what data that they collect and how they collect it and the form that it's collected. Some agencies limit who uses their data system, others allow tons of people to use it, and so the quality issues are there. So these have been some of the biggest challenges that the communities we spoke to have had to overcome. And this is, after speaking to so many of them, some of the ways that they've really been able to overcome those systems and those challenges. And I'm not going to talk about these specifically today. They'll be in a report, which is coming out in a couple weeks. But what I really want to do is turn to our partners, because they're going to be able to tell the stories about how they've handled and overcome some of those obstacles. And what I want to share about these 3 organizations and communities that undertook robust cross-sector data sharing and collaboration is that they all 3 really undertook a fundamental shift in how they work. They were patient, they were persistent, and their approach was to see the client as a whole person and not a housing client or healthcare client, but to really see the person as a whole. So I'm going to turn it over to Alameda County, Christy Iannuzzi from the Bay Area, and let her tell the story of how Alameda County approached their work. Thank you.
Thank you, Julie. I am Christy Iannuzzi. I'm with principal with CNC Advisors, and I am acting as the Director of Strategy and Implementation for Alameda County's Social Health Information Exchange. I'm going to talk a little bit about how we got started and really what our vision is. So whole person care is actually a California waiver program, 5-year pilot program that's really focused on care coordination best practices for people who have complex needs, primarily medical, behavioral, certainly housing and other social determinants. And Alameda took this opportunity to really invest in the really specific infrastructure to include the development of process and systems for true interdisciplinary communication, data sharing, and care coordination. And we're looking across a range of crisis settings, emergency departments, psychiatric emergency, EMS, homeless service settings, other crisis centers like jail, and building the support services that help them avoid that crisis, right? We're gonna come at this with an equity lens and really be sure that we are looking at that whole person perspective. Next slide. The technical infrastructure, and we're gonna talk about the systems that we pull together, really have 2 components. The Social Health Information Exchange, which really has 2 components. It's a community of organizations that have agreed to share data, and there are agreements and laws that support that. It's also the technical component that is designed to keep data secure, to exchange this kind of complex cross-sector data, managing who can see what, and most importantly, really matching that identity. So what Julie said is exactly right. They touch multiple systems, and has been very difficult to both find them in those systems and match them. The community health record is an application. It's the portal with which they really a group of providers really draw from the Social Health Information Exchange. And we rolled that out in late 2019. And it allows them to see a curated view of the data that we're going to talk about later. We have more than 30 organizations. We have more than 1,000 users. So, lots of people are already using these programs. Go ahead. I want to talk a little bit about all of the components of the Social Health Information Exchange because they're all very important in how we dealt with patiently and with persistence, the challenges that when you bring multiple disparate agencies together. We have a data governance committee that we started very early on, and it includes 15 representatives from various sectors of the data sharing participants that really help us guide the decision making. We also have representatives from the peer community so that we can also get that perspective. Really the focus is not to make decisions for healthcare services, but really to guide those decisions to steward the data properly. We also have a security privacy work group that is really focused on laws, opportunities in interpreting the laws, providing feedbacks on policy changes that are coming through, be really accountable on the audit side, and also give guidance to that data governance committee. Next slide. There are also some very important documents that link us all together. There is a data sharing agreement that is really focused on how the rules around how we are going to both contribute data and receive data. So the data, not all organizations contribute data, but the ones that do have almost identical agreements on how that data exchange will operate and how we are going to treat that data. The information sharing authorization is what we might consider standard consumer consent. It's integrated into the front end, that application that we talked about, the community health record, for a consumer to agree to share data. This is extremely important for our covered entities, but is primarily important for our non-HIPAA covered entities. Thank you. Certainly, there are a lot of regulations that cover how we share data. HIPAA's TPO, treatment, payment, and operations, is certainly one of our guiding pathways. Consumer consent is a primary driver for non-covered entities, and how a user is in the system. Everybody does not use this system. Users who are primarily focused on care coordination and really focused on consumer care are our primary users in this system. We also focus on a unique organizational attribution of records. So an organization, and this is guided by the data sharing agreement, an organization can only view a consumer's record if it holds care responsibility for that consumer or has already provided service to that consumer. The care relationship is identified through data feeds or self-attribution. So we have a lot of data feeds coming in. Some of them are the ones in the clinical world that are referred to as ADT feeds, admission, discharge, transfer feeds. Some of that is health plan records, and so traditional claims. Some of them come from our housing homelessness management information center, where they are attributed there and is fed in. At this time, we're really focused on what is a traditional safety net. I know that's sometimes a loaded, a loaded term, but really right now we are limited to Medi-Cal and uninsured. Some of this has been part and parcel of the Whole Person Care program, but really has expanded to all uninsured because, as we know, people fall in and out of Medi-Cal all the time, right? So we want to catch those people as that process happens and get them back into care. Next slide. We really developed a best of breed technology solution to manage this. There really isn't a silver bullet or one system that's out there that has done this. We're doing things that really haven't been done before. For us, primary component was taking the data and matching it. For those of you who come from the clinical world, not too hard to match that data. We start to bring in homelessness management information systems. We bring in jail data and other non-standard data sets, and we have a real challenge on our hands. We also had to build a privacy and security infrastructure that made our partners confident and secure that we were taking care of their data, we were attributing it properly, and that we were integrating patient consent. We did that by putting a primary tool together. The name of the company is called Thraces, but we glued that together with Collective Medical Technology, which is a platform that provides ADT feeds, letting us know in real time so that we can provide real information to the care managers when somebody has touched a system. We have a sophisticated matching system that we integrated into those products called Verado, which really helps us on the matching side. We have recently integrated digital signatures with DocuSign. Pandemic really kind of pushed us into that digital signature world. And then really on the portal side, we've talked a little bit about that already, but the community health record is that portal that gives that information and really helps manage consent. This is the kind of data that is available. We integrate care team members and social contacts. We are letting our housing providers know. Our clinics have always had pretty good information about Medi-Cal coverage, but our housing service providers have often been in the dark about whether somebody's covered under Medi-Cal. We have a robust, rich clinical data set, but we have included mental health services, which really, even for the clinical side, has been sort of a black hole in where our clients are receiving services, and certainly has helped on the housing side. Clinical organizations know clinical data very well, but they don't know the housing systems very well. And so we're introducing them to a set of data that they've never really seen before, and we're helping them understand what they're supposed to do with it. We have current county jail incarceration, again, a key component to our real-time alerts that are coming across. And then we also have some social services data and some what we call CCDA files, which is detailed hospital discharge information. Next slide. You know, really a big component of this, both to build trust and to really help us with data quality and the products that we bring to the community, has been really engaged in understanding the data quality and then conferring with our data partners so that they understand where that quality is and how they can improve that. We've had some challenges on user engagement. This is a non-mandatory system. We ask them to use this system to coordinate care, but we are not their primary system. So we have had some challenges, and we've had to build in that community input so that they can help us get these consents signed. And, you know, we help them with things like how you use jail data, right? They've never really touched that data before, and they need peer feedback on how to do that. So we're on the front lines with our users, trying to make that data more understandable, what you're supposed to do with it, make it easy to navigate, and prioritize the data sources coming in, right? We can't deal with everything in this 5-year program, but we're bringing in the clinical data sets. We've prioritized jail data. We've prioritized HMIS, making that clean. We've had a lot of changes in Alameda with coordinated entry. That changes all the time, and we have to be really focused on that. And recently, we have adapted to virtual training. So we are developing, while we've been really hands-on on the learning process, as we get to so many users, it's been really difficult to support. So we are transitioning into a self-paced learning management system, or LMS, and really adapting to kind of the world that COVID has brought us, right? That pandemic world. And we've really adapted to that and leaned into what our users need. So I'm going to pass over to our colleague, Chris Kuntz. He is the Chief Policy Officer for San Diego's Regional Task Force for the Homeless. You're on, Chris.
All right, thank you, Christy. Hi, everyone. Chris Kuntz, Chief Policy Officer with the Regional Task Force on the Homeless here in San Diego. And I'm going to talk kind of say broadly about some of the work we've been doing in San Diego, but I'm going to focus specifically on the work of the Community Information Exchange, our CIE, in partnership with 211 San Diego. So real quickly, the Regional Task Force, who we are as an organization, we are the HUD Continuum Care Lead Agency for San Diego County. We are, in that role, we do various things like coordinate our annual homeless census. We do our coordinate entry system. We also administer our homeless management information system. So we're a nonprofit organization, which is somewhat unique for a continuum care lead agency. Many are embedded within local government, but as the COC lead, kind of regional convener, policy, kind of a leader on homelessness in the region. So, and we're also a direct funder. Some of our state funds and some of the federal funds flow through our organization. Real quickly, 211 San Diego. I think most folks know 211 is kind of that information referral system, but they are all I'd say, a diamond in the rough and the backbone of our community information exchange. So next slide. There we go. All right, so this is a little bit of a busy slide, but I wanted to walk folks through kind of what we've been doing in San Diego and kind of the evolution of our health and housing partnerships and where the community information exchange fits in. Going way back to 2010, one of the kind of initial things that really got our system going here was a frequent user pilot, Project 25. And this was a local initiative spearheaded by our United Way that focused on taking the most expensive folks off the streets, putting them in, using a housing first model, putting in permanent supportive housing, and measuring the progress of folks. And what we found was that it was wildly successful. It was a really exciting collaborative model between the County of San Diego, the City of San Diego, and the San Diego Housing Commission, which is our public housing authority, Father Joe's Villages, which is a large homeless services organization, and a health center operator. And I think this kind of mixture of social services, of healthcare services in a clinic setting, with housing vouchers and rent subsidies, that kind of mix of things coming together was really, was the ingredients for success, and it's kind of what has flowed through the rest of our partnerships. So the pilot did kind of transition into our, we call it whole person wellness in San Diego, but our whole person care pilot was really kind of the scaling of Project 25. It focused on targeting homeless high utilizers with kind of complex health conditions, right? So Project 25 kind of moved our system forward and kind of in our whole person care pilot. But what it also did, it was also the first use case of our community information exchange. So Project 25 was kind of sharing data with various partners, including our city's 911 system. We were getting kind of alerts, when folks would get picked up by the 911 system and taken to a local emergency room. And so this kind of pilot also, it really kind of helped kind of build this idea of how do we share data across sectors to do good care coordination. But kind of moving forward, our whole person wellness pilot, I think, really brought together a lot of different people to the table, right? Healthcare providers like hospitals, health plans, FQHCs, housing providers, other social services providers. And so it really kind of now has moved forward with our CalAIM planning and soon to be implementation. So next slide. So the community information exchange. A lot of times people think the CIE is just a integrated data system that connects disparate databases for the purposes of care coordination. And while the data system is kind of a core piece of it, we really have to think of the CIE as this kind of ecosystem of collaborative kind of network of partners really coming together with common goals. And the data platform is kind of that is there, but we see it as a broader kind of effort. Next slide. So kind of building on that, again, some of the core components of the CIE that 211 San Diego oversees and kind of brings folks to the table is that network of partners, right? Kind of a collective network of partners across various sectors. And I'm not just talking healthcare and housing, I'm talking food banks and workforce development and a whole other host of kind of social determinant of health organizations coming together, because we all know that we, collectively, we are working with a lot of times the same folks. Shared language, we have kind of, there's these kind of referral mechanisms in there. And obviously I'll talk about the tech platform here in a second, but this idea of moving towards this community care planning together. Next slide. The partners in the CIE right now, 100+ partners, and again, across a variety of different sectors, healthcare, housing, you name it. Next slide. All right, so I am totally not a tech person. I will try to explain this the best I can. That the folks at 211 can do it much better than I can. But in simple terms, the idea is that the CIE kind of takes data from disparate databases for common folks, right? Puts them into what we call what is the CIE, which is a shared record. You can see an example of the shared record, but it connects data systems. The platform we use is a Salesforce platform, but it allows for alerts, and we have things like a single sign-on. So when you sign into your own host data system, you're also signing in to the CIE. So next slide. So I'm going to talk a little bit about CIE in the homeless system, and then I'll do the same for the healthcare system. So homelessness, like I said earlier, was the first use case for the CIE way back in 2010. Many of the CIE partners are housing and homeless providers, and about a third of the users of the CIE, actual staff that are logging in and using it for care coordination purposes, are homeless services staff, whether that's shelter programs or outreach workers, permanent supportive housing staff. And I think one thing that we're really proud of in San Diego from kind of the perspective of the regional task force as the homeless management information system lead is that we worked really hard with 211 to get a common consent developed. And so in San Diego right now, there's HUD has different kind of privacy practices for data sharing within the HMIS system. And so what we've now done is that when someone experiencing homelessness shows up to the homeless services system and consents to share their information within the network of HMIS of homeless services providers, at the same time, they are also, that same consent form is also allowing their information to be shared much more broadly into our community information exchange, into the network of partners beyond just the homeless services system. Next slide. So the CIE has a variety of different healthcare partners, kind of in different levels of participation in the CIE. So health plans, we have several of our health plans in San Diego that are partners in the exchange and have things like view-only access. So their staff can log into the CIE, look up patients, understand their kind of housing and food and workforce histories and kind of what things they are participating in. We're also, the 211 is working with some of the health plans on some data sharing within the exchange, which is starting, which is exciting, right? Hospitals, same thing. We have a number of hospitals systems in San Diego that are strong partners in the CIE. They're a lot of their, emergency room, discharged social workers have access to the exchange, can look folks up, connect people, that are discharging from the hospital. We have some limited data sharing kind of happening right now as well within the hospitals. And then we have a whole host of FQHCs that are partners in the exchange. Again, kind of view access. We are testing some sharing from the health centers into the CIE, putting healthcare data in the CIE. And then two other things I want to highlight is the County of San Diego has their Connect Well system, which is kind of this integrated system of all the county's various programs, behavioral health and child welfare, probation, et cetera. So the CIE is also connected into that system, which is really awesome. And the last thing I mentioned already is that this partnership with the City of San Diego's 911 system. And so lastly, I just want to touch on some other efforts that I think are kind of where we're going next. And 211 in the CIE really is that kind of bridge across these things, right? That is, the CIE is our integrated care coordination tool in San Diego that connects various systems to improve, improve care and housing. So, but under the homeless continuum of care, we have, we have some committees going right now that's, kind of bringing health and homelessness partners to the table. Our organization, along with Father Joe's Villages and FQHC, we're participating in the CHCF State Learning Collaborative around health and homelessness. Our organization contracted with Brilliant Corners, a well-known organization across the state, to develop a flexible housing pool in San Diego. And we really see that as an opportunity to bring some of our healthcare partners to the table in a way to house folks, their patients who are also our folks on our streets. And we've actually had a really strong partnership with Kaiser Permanente, who has, we are really focused on Indian veteran homelessness here in San Diego, focused on Indian youth homelessness, and Kaiser Permanente stepped up and helped fund some of the infrastructure at our organization and community solutions to help drive towards those goals. Kind of shifting out of the homeless system and into I would say our healthcare system. Our Healthy San Diego is our kind of collaboration of our Medi-Cal managed care system. Right now, San Diego has 7 health plans, but the Healthy San Diego umbrella kind of brings a lot of folks to the table, kind of under this collaborative model of healthcare partners and housing partners and behavioral health partners. And so that's what a lot of where our kind of planning is happening, along with kind of at the homeless continuum care level. So, and I think we're really excited about what CalAIM is going to look like for San Diego. A lot of our housing and homelessness providers are currently, health home contractors or contractors within the whole person care pilot. And as that stuff transitions, we're excited to see our health and our homeless and housing partners kind of continue to do that good work, for folks. So I think that is all of my slides. And I'm going to pass it over to Tina Rivera. Tina is with Sonoma County.
Good morning. It's great to be here with you, and I'm happy to share with you our efforts for Access Sonoma's Data Hub project. Back in March of 2018, Sonoma County, we entered into an agreement with IBM, or International Business Machines Corporation. And this was to provide a software and implementation of accessing coordinated care and empowering self-sufficiency. So Access Sonoma Data Hub project was born here in Sonoma County. And these efforts were to support our county's rapid response safety net services efforts. And so what we were seeing were challenges within our system. We had siloed programs where our services and programs were not integrated. We were serving many of the same clients, but we were not collaborating. There was very little staff collaboration around the client. We had an inefficient service delivery system. And coupled with those siloed systems, we were unable to share information that would enable us to have an effective service delivery system for our clients. And then added on to a siloed funding system where we had categorical funding, which limited our collaborative programs that we could see. So this led to, of course, poor outcomes that we were seeing with respect to our clients. These poor outcomes meant there was a lack of integration that was going on here in our county. The poor outcomes led to, a lack of promotion with respect to a client's well-being and self-sufficiency. And then there was costly and administrative burdens that were placed upon our systems. And as we all know, that we can understand that the definition of insanity is doing the same thing and expecting different results. Next slide, please. So what we thought was we needed some solutions. So what was going to be our solution? Well, we thought, how about an integrated services and care management system? What would this look like? So this could mean that the staff and the community could come together and partner and work together. What we could see is coordinating care and problem solving together. We could come together and set goals for our clients and coordinate the care around our patients. What would this mean? Well, we could add an enabling technology. What would that look like? Well, we could share data across our programs and across our systems, and we could access together some critical information around the care management of an individual or of a family. And this could be accessed, we thought, anywhere, anytime, if we could have an enabling technology that could be mobile. And we could add some braided funding where we could have funding that would break down those silos, where we could share this data system and integrated care management, put together a team that could come together where we could pool some funding, we could address those gaps, and we could have a collaborative care system. Wow. What would that mean? Well, we could get rid of our poor outcomes that we were seeing, and we could look forward to some successful outcomes. We could have successful outcomes in our housing and sheltering systems. We could look forward to successful outcomes in behavioral health and our medical services that we were providing to our clients, food assistance, and improve the well-being and stability of our clients. Next slide. So Access Sonoma County was born. This was our model. And it was threefold. It was a collaborative model. It was an innovative model, and it provided access. And when we talk about collaboration, this allowed us to work across programs together. We were able to form multidisciplinary teams. These were teams who had skill sets, and they could bring those skill sets to the table across our Sonoma County departments. And this would mean that we could have better outcomes because we could serve our clients better by having the skill sets at the table, and we could collaborate one together with respect to those our residents who had these particular needs in a coordinated fashion one together. And then with respect to innovation, well, we could utilize these processes like design thinking and tools like Connect 360 and Watson Care Manager to facilitate some forward-thinking progress. And then access. This was so important. We could ultimately, it's always about our residents. And so those who are vulnerable, those who are most at risk, these are the individuals that we were seeking out. So we're able now to provide access to client care that we weren't able to do before. We're able to do this on a daily basis for those who have needs at the greatest time of need in their lives. Next slide. And so we formed an Access Sonoma organizational leadership team, if you will, a safety net collaborative. And this involved several different departments across our county departments. This involved our health services department, our human services department, our community development commission, our justice partners, which involved probation, our district attorney, our public defender, our sheriff's office, and then also our child support services. So what we were able to do was to come together. We were able to engage in policy developments. We were able to start making some funding decisions. We were able to do some budget planning and take these items to our Board of Supervisors. We began making some staffing decisions and able to develop our cohorts and staff those cohorts appropriately to reach those goals and objectives that we had begun to set. We were able to really take a look at discharge planning for families and for clients. And then we established an interim encampment policy. As you know, encampments are really have become an issue within the state of California, even nationwide. And so what we did is we came together and established an interim encampment policy and began to put together some prioritizations around those encampments and how we would address those encampments. And we were able to establish a cohort around those particular encampments. Next slide. And so some of the operational objectives that we began to take a look at was the burden of care. How were we going to reduce the burden of care? How could we achieve system integration in a more effective way? Could we take a look at creating stability in client lives and really look at creating a care plan around self-sufficiency and boosting some operational efficiencies in the way we did business on a daily basis? So we looked at ways that we could improve the health of our clients. We looked at our outcomes. We looked at those poor outcomes prior to Access Sonoma, and then looked at, once we began to roll out these initiatives and with Access Sonoma, how those outcomes began to improve and what we were able to do and see as we now were in a more integrated and collaborative system that had the access that we need. Then we began to look at increasing the number of people who were able to access services. This was a no wrong door approach now. And then we were able to improve our referrals. We were able to now have a better quality of service for our clients, because ultimately that's really what this is all about. We were able to increase coordination as we came together around the table to strategize around the care of families and individuals. We improved communication between our care management teams, and then we decreased the expenditures per individual and per client. So around our policy objectives, we entered into a partnership with California Policy Lab, who provide data and analysis for us on those high utilizers. And we've really been able to get some really great data and some analysis as we look at gaps in service and what we need to be doing and what we need to be looking at. We've been able to identify some shared high need vulnerable populations and take a look at how we can better address that with the establishment of our cohorts as we move forward. We can analyze that data better because we have an integrated care plan and we are collaborating together. So we're now able to create tools that measure and target these high need populations. Next slide. So some of the enabling technology that we're now able to look at, you can go to the next slide. This Access Data Hub does some really incredible things. It's an integrated data hub. There are several systems that this hub is able to pull from. It gives us a holistic view of the clients that we work with. It's a cloud-based system. It's a mobile care coordinated system. It's shared by all the teams who have access to the system. So for instance, we're able to pull housing data up through this particular hub. Not only are we able to pull housing data or housing voucher data, but we're able to pull encampment data. For instance, how many encampments were we able to send our outreach teams to? How many encampments were we able to clear? We're able to pull our Watson Care Manager data. And it's de-identified data that we're able to pull up through the hub. So we're able to really just kind of look at how many individuals are we able to service around our county? What areas are we servicing? Those types of things. It's a community-based participation and referral system. So it has that particular capability. We're able to engage in our sheltering with our sheltering partners. So we're also able to pull our sheltering data up through the hub. So we're able to see in real time with respect to how many beds do we have available. We're able to pull those that data up through the hub and begin to see in order to coordinate the care that we need. Eligibility data, we're able to pull through our CalWIN system. Next slide. This particular slide gives you kind of a look at a particular client. This is Miss Sandy Beach, not a real client, of course. Now, we're able to see these particular elements within Miss Sandy Beach's on her within her client screen. For instance, the protective factors show us, it provides the care team or the multidisciplinary team some insights into some of the strengths that can be applied no matter what the program that we're looking at. Provides us a picture of her job skills, the employment history, any recovery history, things of that nature, any planned actions that the care team may have implemented, things of that nature. The care team screen will allow us to see who is on her care team, who has been assigned to her care team. So we're able to have the contact information for the care team, who is touching this client. So who's coordinating care for this particular client. With respect to the program screen, this allows us to see what current actions, what programs is this particular client engaged in. And then the goals just allows us to highlight the areas of focus for this particular client. Those current actions just tells us what has been discussed with the client, what care plan do we have this particular client engaged in, things of that nature. Next slide. This particular screen just allows us to pull, we can pull particular demographic data with respect to this client, any justice data, any substance use disorder, any physical health data, any housing data that we may need to access around this particular client. So this particular screen can allow us to pull these particular demographics around this particular client. Next screen. And then also this particular screen will simply allow us to pull data with respect to what programs specifically this client is engaged in, what the status of those programs are. Is this client actively engaged in those particular programs? And then when did the client start in these particular programs, and when did they end with respect to those particular programs? Next slide. And then I just want to quickly share with you the blueprint of Access Sonoma. This is a model as a blueprint. It's scalable with respect to across cities or counties or states. The Access Sonoma initiative has been highly successful. It assists vulnerable individuals to achieve, whether it be stable housing or stability in their lives, or self-sufficiency or independence. It's an award-winning initiative. This particular project has won 3 awards. We've been told we've recently been awarded another NACO award. And local jurisdictions, as well as other states, have been reaching out to us with interest about implementing this particular initiative. So we're really excited about the possibilities. We've completed the first 5 phases of this particular initiative, and we are excited about the reporting phase because, you know, we were really excited about all of the input and the things that we were able to access. But now with respect to the hub itself and all of the information that the hub provides, the de-identified data as well, we now have created a dashboard that we hope to provide. This dashboard provides de-identified data with mapping, and we'll be able to create customized reports from the hub that will assist us as we continue to, you know, in our decision making and our policy creations around addressing housing and homelessness and health decisions around our families and our communities with respect to those that we serve in our vulnerable populations. So that concludes my presentation, and thank you so much.
Thank you so much, Tina. I'm going to ask all of the presenters to go on video, and we will start taking questions. I know there have been a number of questions already in the Q&A, so go ahead and come off video. And we'll start with a question for Christy. And people have appreciated all the work you all did. So I just want to say there's some chatter about that. But Christy, the question for you was if you were working with your 2 managed care plans to help the plans identify people experiencing homelessness and exiting jails.
Yes, actually, certainly the health plan partnerships are critical to care coordination in particular. So for the whole person care program, roughly at the same time, there was a similar program rolled out called Health Homes. And so they've used this community health record to support them in health homes. And certainly we're talking about the idea that we would be moving all of this infrastructure under CalAIM. So CalAIM is the next sort of, the 5 years that we have been practicing CalAIM that was the dress rehearsal. This is the show.
Great. And I think in general, there's questions that might be helpful if you all talk about jail data, because, there are concerns about implicit bias and, bringing in the criminal justice system. So if you could explain a little bit about how, each of you talk a little bit about how that information is being used, because I think that, that has raised some flags with some of our audience. Sure. You want to start, Chris?
Sure, I'll start. So in San Diego with the Community Information Exchange, at this time, we are basically incorporating the publicly available data from our jail, right? So arrest data, discharge data, but it's all the data that's actually, publicly available that someone can get on, I don't know what the website, the Sheriff's Department's website and look someone up. So that's the only data that we're incorporating from the jails at this time. And, as far as kind of law enforcement and criminal justice kind of staff or, personnel using the CIU, we don't do that right now. So that's been a good conversation that we've been having at the local level with, because I think there are times, probation officers or jail discharge planners or, things like that, where I think it can be helpful. We're just not there yet. We're still kind of having those conversations of, what does access look like in the exchange, for criminal justice partners. And I think we recognize there's a need. We're just not there yet. So.
How about Christy?
Yeah, I mean, I would echo what Chris says. The data we're including is publicly available. We worked with a large peer community to really help us understand what we should be displaying in the community health record and for what purpose. And so again, what can we do with it and why it's so important to be cautious with this data. This was an education process that many of our partners needed as a part of becoming a community health record user. I will say that, my medical director likes to say that when someone has been taken to jail in the housing and clinical world, it's like they've been abducted by aliens. They don't know what's happened to their client. They disappear, they're off their meds. They're often in a behavioral health care crisis. And this has really alerted care managers. And by alerts, I mean the moment that they are arrested and then the moment that they are discharged, which truly is one of their most vulnerable moments, has really changed care coordination and how they are helping clients get out of crisis and into stable care, to not lose their housing, to not lose their place in line, and to really get them back into covered care. So we've been really thoughtful about the integration of this. It took us a long time to get the visual part of this available. So,
Tina, anything additional to add?
Now, with respect to jail data, we do work with justice partners, but the client signs a consent to allow those care partners to have access to those particular records. So it's not, available to the community at large, those particular, records around the client care. So those particular care partners have access to all of the data around that particular client, jail records, medication records, all of it, so that they can have a holistic view of where that client is. If there is other appropriate justice needs for that client with respect to probation issues, because all of the departments are at the table hammering out plans, if you will, with respect to that particular client care. Now, when it comes to the hub itself, who is where the hub is pulling data from these sources, it's all de-identified, so it's not going to pull any of that any of that consented data for the dashboard. It simply pulls those de-identified data that is available to the community for the community view, just numbers, if you will. So
great, thank you. Folks had questions. I think maybe we'll start with Christy. If someone becomes housed, are they still in the system, and what kind of, like, will the quality of their housing or potential health impacts become something that is continued to track and addressed?
Well, typically clients that are in care coordination or who have touched the system and have been unhoused and are housed, our idea is really to keep them, once you're in the community health record, you are in the community health record. It's a health information exchange at its base, and clients come in and out of crisis. They lose their housing. This is a journey, and so most of these care managers, continue to follow their clients once they're housed, and help them manage their clinical and behavioral health care issues on an ongoing basis. So, our goal is to get clients out of crisis so that they don't have to be managed intensively, but their records remain in the system.
Thank you. And for Tina, someone asked, if someone's homeless, how does that appear in the virtual client record for Access Sonoma?
Yeah, it will show that this individual is unsheltered. And of course, the goal is to work with someone from the care team or the multidisciplinary team who may be a housing negotiator to get them sheltered or housed. So that individual will work robustly with that individual to get them sheltered.
Thank you. People asked all three of you if you've ever had a situation where an elected official asked you for identifying data about a client, and if so, how did you navigate that? Maybe Chris, we're seeing all no's, so just to reassure folks, it hasn't happened yet, but don't give us any ideas, or don't give the elected officials any ideas. Another question is, I think this is for Sonoma, Tina. When someone's on your waitlist program, how long will they have accessibility to affordable housing? Does that make sense?
Yes, that depends. Now, is it a housing voucher, or or is it a housing voucher wait list is quite long. I would, unfortunately, so that could be a few years long. So I hope that answers the question. I'm not sure if that's what what they were asking.
I'll try to put up our slides in a second with our contact information so that folks can follow up with any of these that the answers weren't clear. This is, again, another general question for all of you, is have patterns emerged from the consolidated data sharing that help you all develop homeless prevention strategies? Maybe we can start with Chris.
Yes. So in San Diego, we put out a report maybe a year or so ago about how we use kind of the back end data to really look at people who are kind of on the cusp of homelessness, kind of in an unstable housing situation, and then looking at kind of their flow through the system and kind of who ended up actually kind of becoming homeless. So we've done a lot of work right there. And in our community, obviously 211 as an entity is kind of one of the first lines of defense for people that are kind of unstably housed and need some type of housing resources. So I think that the nice part where their community information exchange is housed under the 211. It's a very kind of logical place for us to do really good homelessness prevention. And obviously in our environment right now, with eviction moratoriums kind of looming and the pandemic, right? I think we're we are actively in discussion on what that, how do we use a CIE? What does that look like for homelessness prevention? Yeah.
Thank you. I'm gonna, we have a very short amount of time left, so I'm gonna bundle up a series of questions really quickly. So I think this is for Christy. One question is, how have you looked at some of the highlighted the challenges for the coming transfer to Cal-AIM? And then also, if you could address at the same time in your sophisticated way, what happens if someone doesn't sign a consent to our services denied?
Let's disconnect the services from the health information exchange, the social health information exchange. There's no connection. So service delivery and your existence in the health information or social health information exchange are completely disconnected. So we share a lot of information under HIPAA's TPO world. So we share a lot of information with HIPAA covered entities under that regulation. And so, while I want to recognize that consent is a very important component, there are opportunities to share data that are covered under law and regulation that we leverage and use. And so, the client consent is important, but I just want to be clear that that's an important component. I'm sorry, I don't remember the first part of the question, Julie.
The first question was, and I cannot get my screen to go down, the issue about highlighting challenges as we move into Cal-AIM.
The health plans are busy. The health plans are really challenged to transition to Cal-AIM with the resources that they have, and being able to cover all of the things that need to be covered under Cal-AIM. And I'm sure my colleagues will say the same thing, that honestly, I don't know how the health plans are going to be able to pull this off in such a short period of time, except that they use our systems to really gain the advantage of already being connected and really leveraging the systems to get, in lieu of services, over to them in an effective way. That I think that's how they're going to get their step ahead. And for many of them, jail is a component. That reentry stuff is going to come up fast. And how they engage in the reentry population, I think they see this as a real tool.
Thank you. I'm sorry we haven't been able to get to all the questions, but I'm going to quickly put up here our contact information and then turn it over to Rochelle. And Rochelle, are you okay if I leave this up for a second for people to get their email?
Absolutely, absolutely. What an amazing, amazing panel. I didn't want it to end. As I close this out, I certainly want to give heartfelt thanks on behalf of Housing California to each of our speakers for sharing your commitment and insights about the critical connections between housing, homelessness, and health, with the dignity of clients at the center of your work. I'm absolutely in awe of the pioneering, compassionate, and innovative leadership of this panel. And I hope that each of you were inspired by their sharing the information, the collaboration, and hope that they brought to bear. I've been asked to remind everyone to check out the virtual exhibit hall. And remember, the more booths you visit, the greater the chance at winning prizes. So please visit our virtual exhibit hall. At 10:45, please join us for a plenary with key housing and homelessness leaders in the administration, including State Controller Betty Yee, Secretary of the Business, Consumer Services and Housing Agency, Lourdes Castro Ramirez, and Secretary Mart Galley. We're honored to have them here with us, and so we hope to see you there. Thank you again for joining us.
Thank you.
Thanks, everybody.